Everybody, I want to respect your time, so we'll go ahead and get started. Let's go ahead and go to the next slide. Whoops. Yeah, this is just who I am. I'm a benefits broker / consultant. I've been doing it for 38 years. So I've been around a really long time and have seen a lot of things, and I've worked in a lot of different parts of this industry, basically them all of them at this point. So I have kind of a good, well-rounded background for healthcare. And I work for a company called CEBS. We're a benefits broker here in Tucson. We do most of the large employers' benefits in town. And we have a lot that are self-insured, and self-insurance comes into play in what we're going to talk about today, as I'll cover on the subsequent slides. Next slide. So what's reference-based pricing? Basically, it's kind of like the hottest new thing to lower your healthcare costs. It gets rid of healthcare networks. So like if you have Blue Cross, you're used to using the Blue Cross network, or United Healthcare, you're used to using their network. So you're going to be getting rid of networks and just paying an amount to healthcare providers based on what Medicare pays. Next slide. Before we get into that, we need to really talk about fully insured and self-insured, because the reference-based pricing is really only done on partially self-insured groups. And self-insurance used to be for only large groups, I'd say 200 or more employees. It has slowly moved down market to smaller and small employers. And now you have some employers as small as, say, 15, 25 lives doing partial self-insurance. I say partial because there still is some insurance to protect the employer from large claims on a person or on the whole group as a whole. Next slide. So on traditionally fully insured insurance, and that's what most people have, especially small employers, basically, the insurance company does everything. They process the claims, they talk to the healthcare providers that make up the network, they manage the claims. Basically, all you do as an employer are pick the plans you want and pay the premiums. When you leave that insurance company, you don't have to worry about claims coming in after you've canceled. They're covered because you paid extra premium during the plan year that was built into your rates to cover that. So it's really like the easy button. I will mention the last dot point on here, production of plan documents. They do provide some plan documents, your insurance company, but they don't provide them all. So you do need to be aware that you need some other plan documents besides the ones that are provided by insurance companies, and your insurance broker should help you do those. Next slide, please. So the advantages of traditional fully insured funding, which again, most small employers have, it's easy to understand. You just pay the premiums. You don't have any liability if you cancel for the claims run out, which is a big deal. You don't need to hire any actuaries to project rates. The insurance company is going to do all that. Some insurance companies will give you free COBRA administration. They'll help you set up a connection with a banking entity for health savings accounts. They have integrated wellness plans. You have the Arizona Surprise Balance Billing Law. And for those of you who don't know what that is, it's basically if you go to a hospital that's in the network and you're treated by a physician who ends up not being in the network, there's some liability protection there for you, which is a nice feature. Also, if you have an employee and let's say they're in a car wreck and they get a bunch of money from the other person's car insurance, they don't have to pay that back to the insurance company. So they can essentially double dip, which is nice for the employee. Next slide. Some of the disadvantages of that, with most insurance companies, You get canned options, i.e. vanilla, chocolate, strawberry, raspberry, etc. You can't really tweak them very much. The funding options, which are fully insured or this partial self-insurance I'm talking about, they're limited to certain size groups and they vary by insurer, but generally speaking at 100 plus, they will allow you to have some more funding flexibility, but that's not true with all of them. For example, Cigna goes down to 25 lives for that. State benefit mandates apply, and all the states have different mandates. And in the old days, you only had to pay attention to the one that your state mandated, i.e. Arizona in our case. But a lot of states have attempted to do what they call extraterritorial mandates. And they're saying, hey, even if your company is headquartered in Arizona, and thus is under the jurisdiction of Arizona's insurance department. If you have employees in New York, we want you to cover fill in the blank, in vitro fertilization. And if you don't do it, we'll sue you. So rather than the insurance company saying, well, you can't do that because you're not in charge of Arizona law, they just comply because they don't want to be sued. So that's kind of gotten messy over the years. There are taxes on health insurance in Arizona, and those apply to the entire premiums charge. The entire premium is subject to that tax, so that increases your rates. Next slide. So you're going to pay the same premiums if you're fully insured, regardless of your claims experience. So if you have a year where you hardly have any claims, you're going to pay way more than you needed to. The insurance company is taking in more than they need to cover those claims that come in after you cancel. They're earning interest on those. So that's a cash flow loss to you. On small group insurance, they are what we call pooling your group with other groups, meaning they're not basing your renewal just on your group's claims. So if they're really low, on your group, maybe the rest of their groups were high, so you're going to get a rate increase, which is a blend of the two, which means you're not getting as low as rates as you probably are due. And then employers can't get that excessive money charged back. At the end of the year, if you paid in way more than they paid out, they made a bunch of money on you. Next slide. So concepts of self-funding. Next slide. So there is a risk-reward continuum on health insurance. And I'm not going to spend a ton of time on all of these, but on the far left side is the least risk, but you have the least ability to really only pay for your claims as they come in. That's fully insured. On the far right-hand side is self-insurance with no stop-loss insurance, meaning you are going to just pay your employees' claims as they come in. If you have $1 million claim, you're on the hook for that. Only the very largest employers do that, like a General Motors. Most of the people that are self-insured are this one next to last on the right, self-funding with stop loss. And that basically is where you're going to pay the claims that come in, but once they hit a certain level on a per person basis or a whole group as an aggregate basis, the insurance is going to kick in and you won't have to pay them those claims above those levels. These other two, retrospective premium, Blue Cross does that retrospective premium at 100 employees, and that's where at the end of the year, if they took in more money than they paid out, you get some of it back. Level funding is very popular now, especially with Cigna, who goes down to 25 lives on that one. And on that one, you pay what look like fully insured rates. And again, at the end of the year, they do an accounting and you can get some money back. As to how much money you get back, it depends on what option you selected. They have several options, from all of the money back, which costs more, to half of the money back, which costs a little bit less, etc. Okay, next slide. So let's jump to the concept of self-funding and who should do it and who should maybe not do it, and the components that you need to look at if you do want to go self-funded. Next slide. Thank you. So who should really consider self-funding? It used to be the rule of thumb was if you had 100 employees or more, and therefore you had claims experience, because most of the insurance companies give you your claims experience at 100 or more if you're fully insured. And thus you knew if you had any really high claimants. And, you know, obviously if you had really high claimants going on, you don't want to be self-insured. So generally speaking, 100 was kind of the rule of thumb. Basically, it was also employers who were willing to, you know, have some risk, because in bad years, you'd pay more than you would in than if you had fully insured. And in good years, you'd pay less so you could keep the difference. So you typically have a CFO that is not really risk adverse, but again, they do want to know what the risks are, and we're able to quantify that. You want a financially stable employer, because if you're going to be partially self-insured, you're going to need to have decent, stable cash flow. You want to be able to partner with a consulting firm like us that knows what they're doing, because if you are partially self-insured and you don't know what you're doing, and you have $1 million claim, and it turns out the person was not actually eligible for your insurance because they didn't work the number of hours per week, or they weren't a US citizen and you didn't know it, suddenly that $1 million claim is denied by your insurance, your stop loss insurance, and you're on the hook for that. So you got to really know what you're doing on that. And again, people who like cutting edge solutions, they tend to gravitate toward partial self-insurance. Next slide. So you want to be a stable or growing company. If you've had experience self-funding your workers' comp, then you're kind of familiar with this. If you like flexibility, if you have employees in a lot of states, if you have young, mostly male employees, this is a good play, because actuarially speaking, younger males tend to ring up the least claims of any age, sex demographics. So if you're like a construction company and you're covering a bunch of young males, you'll generally do better than fully insured if you go self-insured. If you like wellness programs, those tend to be more popular with self-insured groups, because if your employees are well, that's going to be reflected in lower claims, and you'd benefit from that instead of the insurance company benefiting from that when they have lower claims. Note the caveat here that you don't have to have all of those categories above to consider self-funding, but you would want to have the bulk of those. Next slide. So who should not do it? Companies with cash flow challenges. If you have high turnover, why high turnover would matter is you've got people coming in to your company. You don't know anything about their health history. You can't ask them about it. So let's say you get a new employee and they've got a dependent who's got some serious medical condition, and they're taking a drug that costs $100,000 a month. You wouldn't know that. If you're self-insured, that's going to hurt you, obviously. So if you have high turnover, you don't want to do that. Companies that have large ongoing claims, and again, you might not know that. We typically see situations where when we do get claims experience, the people who are ringing up most of the claims are spouses and children. So you really wouldn't know that as the employer. You would know that, you know, your employee is out of work and he needs a surgery. So you'd know about employees, but their dependents you really wouldn't know about. So again, that's why it's good to have claims experience before making these decisions. But I can tell you a way you can kind of get around that and do the same thing. Okay, next slide. If you're self-funded, you can pretty much have your benefits broker / consultant design your plan as you want. So you have a lot more flexibility. Now, granted, there are mandates that you have to comply with, but you do have a lot more flexibility. You're going to get much better reporting. Reporting means your claims experience, and it also means utilization reporting. So not only do you get, we rang up this many claims last month and last year, but you also know where those claims were. So we had a lot of mental health claims. So maybe we should consider an EAP. Or we've got a lot of diabetes claims. So maybe we need to start doing some weight loss wellness those sort of things. It's lower cost typically to be partially self-insured because there's lower taxes and you're getting rid of the insurance company's profit. And I would like to point out that insurance companies always say, we don't make a lot of profit. If you look at our profit, I remember I saw a study, it was 3.3%. That's not an excessive profit margin. But what they don't tell you is they're getting kickbacks from the drug manufacturers. And those drug kickbacks are a lot of money. And those are kept secret from you if you're fully insured by most of the carriers. So, you know, they do make a decent amount of money. If you go partially self-insured, you're going to eliminate that money. As I mentioned earlier, if you're just paying your own claims, as opposed to your fully insured premiums, if claims come in low, then you're getting to recoup all of those savings because you're only paying for the cost of the claims that actually come in. And subrogation is allowed. So again, if your employee has a car wreck and they get $1 million settlement and their health claims were $500,000, they'd have to pay half of that settlement to you, which is good for you, not great for them. So it depends on your perspective whether that's an advantage or not. Next slide. You don't have to comply with all of the state mandates. You can put in more robust cost and utilization controls. You're going to be holding your own claims reserves for that run out period. So to the extent you could do something better with that money invested in your business or whatever, you'll come out ahead on that. More control of the plan design, and the ACA exempts self-insured plans from the health insurance industry tax. I would like to point out that that tax was removed this year for fully insured groups. It was removed by the prior administration. So you might look for that tax to come back next year. That tax was about 4%. That's going to go straight on your premium rates if you're fully insured. Next slide. Some disadvantages. Right now, let's say you have Blue Cross. You're just dealing with Blue Cross. You can get self-insurance from Blue Cross and United and Cigna, and that's called bundled because they're going to be doing everything for you just like they're doing right now on your fully insured program. But a lot of people who go self-insured, they unbundle everything, and they do that to get the best in class vendor for everything. So you're going to need to hire somebody to administer your claims. That entity is called a third-party administrator, or TPA. Blue Cross can serve as your TPA. United Healthcare could too, but there are 1 million standalone private TPAs in the United States. They're generally cheaper than an insurer as far as administering claims. When you're fully insured, you know what your liability is. It's basically you paying those premiums every month, and then it's the easy button. You don't need to worry about what happens. You're going to lose that security blanket if you go partially self-insured. Sometimes you'll be paying less than you would if you're fully insured. Sometimes you'll be paying more. Your worst case scenario, if you're self-insured, is going to be worse than your fully insured rates. So again, if your claims come in low, you make money. If they come in higher, you'll potentially pay more. And that potentially more is usually 25% more. Sometimes it goes down to 10% more. It just varies on the insurance company and how much you want to pay. If you're partially self-funded, you do have to worry about the claims run out if you cancel. So if you're fully insured, you cancel, no problem. You switch to another insurance company. The old one's got to cover all the claims that come in after you cancel. They can't charge you anything more for that. If you're self-funded, you do have to worry if you cancel about what's going to happen to those claims that come in later. You can sometimes get the new third-party administrator and stop-loss carrier to cover those. And it gets a little complicated, and that's a discussion for another day, but just keep in mind, you do have to worry about what we call the claims run out, or incurred but not reported claims. CBIZ has an actuarial department who estimates what that is for you every month, so you would know kind of what you need to set aside, and you can build that into the rates you charge employees. So it's not as scary as it sounds, but it is a disadvantage compared to fully insured. Next slide. When you're self-insured, if an employee is unhappy with a claims decision, typically you're the one that gets sued because you're kind of now the insurance company. You can pass that liability to your third-party claims administrator for a fee, and we always recommend that you do that. When you're fully insured, you're just paying your premiums once a month, easy peasy. When you're self-insured, whoever your third-party administrator is, they are going to need the money for the claims that are coming in, and typically they do that via an ACH once a week or twice a week, and they give you a day's heads up. Hey, we need $50,000 to be in the account by 2 days from now or whatever. But you know, that's going to involve some work on your part. You become a covered entity under HIPAA. What does that mean? It means basically, since you can see your own claims now, you're going to know that employee X has leukemia or what have you. You're going to know that spouse Y has cost $100,000 in claims this year. To protect against abuse of people's privacy, you have to name a privacy officer at your company, and you have to prove, if you're ever audited, that you had privacy protocols in place dealing with the ability to see your claims information. To get that covered, you can pay your TPA or another TPA to give you what's called a HIPAA package. They're usually about $500 or $600, but be aware that that is a factor. The other thing I'll just mention about that is sometimes groups don't want to know about that stuff. I've run into situations where the HR folks said, hey, we don't really like this idea because we're concerned that the president of the company or the CFO is going to look in there and see that John's ringing up a lot of claims and they're going to try to get rid of John. And I've actually seen that happen. It's horrible, but be aware that because you have the ability to look at claims, sometimes that can cause unforeseen consequences like that. You'll also lose that Arizona balanced billing law, but the federal government's got one that's forthcoming, so that's not going to be an issue for much longer. Next slide. So basically, this is just a chart, and it shows all things being equal. If you go from fully insured to partially self-insured or partially self-funded, you're typically going to save between 5 to 8%. And that's not really due to claims. That's just due to the cash flow savings and the tax savings. So all things being equal, you'd save about 5 to 8% of claims, assuming your claims were the same as they otherwise would be. But again, if claims come in low, since you're just paying the ones that come in, you can save quite a bit of money. Next slide. So if you are going to look at self-funding, you've got these 5 things here that you typically need to get, and your broker or consultant, if they're experienced in this world, would help you. The third-party administrator, again, they administer the claims, they're doing the billing, they're doing all kind of the paperwork. The stop loss is this insurance that applies to claims per person or on your whole group. And obviously, the lower that you want that liability, the more you pay in insurance premiums, just like on your car insurance. Pharmacy benefit manager. If you have, say, Blue Cross or United or Cigna, you're getting your prescription drugs from them. If you're self-insured, you are getting them from a pharmacy benefit manager who basically is in the job of providing prescription drugs to self-insured plans. And as you may know, Cigna, Blue Cross, United, they've all bought big pharmacy benefit managers because they want to get in on that action. As I mentioned, there's lots of what we call rebates, which is basically the drug manufacturer and the pharmacy benefit manager get together and say, hey, there's 5 drugs that treat condition X. We will only cover your drug if you will give us a big rebate or a kickback. And that stuff happens, and the pharmacy benefit managers make a lot of money, and typically they don't, in the fully insured world, they don't pass it along to you. In the self-insured world, you can get transparent ones that will pass all that money back to you. So you can save a lot of money on that. CBIZ has a pharmacy benefit manager consultant who's a pharmacist, and they basically look at all the deals to make sure that you get a transparent one and one that has good pricing markups, because they mark up the cost of the drugs. You can save typically a ton of money by looking at that. That's been one of the biggest ways to save money in the last couple of years. If you're over 250 employees, we also have things called pharmacy co-ops, where these pharmacy benefit managers will basically put a lot of employers together and make an even bigger pie, and they can get even better deals on drugs by doing that, which they pass along to you. You want to rent a provider network. And that means, you know, like the Blue Cross network or the Cigna network or somebody like that. UHC does not rent out their network, but you can rent out other people's healthcare provider networks. And you want to do that because those healthcare providers have agreed to give Cigna, Blue Cross, et cetera, like a 50% discount. So if you don't rent a provider network, you're going to be paying way, way more than you need to. So you would typically need to rent one. Population management vendors, these are people that help you control the cost of your claims. So they'll identify large cost claimants and try to steer them to the best hospital that deals with the surgery they need. So they basically just try to help you manage claims, and they're very successful at that. So you do want to get somebody like that if you're self-funded. Next slide. All right, so now we'll get to the meat of the reference-based pricing approach. Next slide. So what are BUCAs? You may hear the phrase BUCA by people like me, and that's short for Blue Cross, United, Cigna, and Aetna. They're the very large national insurers. They have gone out and got discounts with doctors and hospitals and lab places and scan places. And those discounts are usually 50 to 60% off the bill. It does vary by healthcare provider type and service. And another little known fact is they don't get the same discount with every doctor. So you might think, you know, Blue Cross has got a 50% discount with doctors. They don't. They got whatever they could get with your doctor when they met with them or their practice. So it varies. Those discounts are passed along to your employees when they use those in-network providers. So the rates that fully insured insurance companies give you are predicated on those discounts. Those serve as an effective barrier to entry for other entities. So like Arizona tried to have a co-op when Obamacare came in. I think they gave them $21 million to get it started. Everybody like me said, well, they don't have any patients, so how are they going to get discounts? And if they don't have any discounts, their rates are going to be no good. So this is just going to not work. And exactly as planned, like a year later, they went out of business because they didn't have any discounts, because they had no bodies to go to the healthcare providers and say, hey, we've got 100,000 people on this plan, give us a discount. They didn't have that, so it failed. Next slide. So here's the little secret that not too many people know. When somebody says they have a 50% or a 60% discount at a facility like a hospital, that sounds pretty good, but it's actually not really good, because it's really inflated to what Medicare pays. So typically what Medicare might pay is going to be way, way less than what they're paying. They're usually paying about 250%, the insurance companies, of what Medicare pays. So basically, just imagine if you could pay what Medicare is paying, you would save a ton of money, and you really don't need the insurance company anymore. So this last dot point says, you know, the insurance companies will allow you to be fully insured or partially self-insured, as I mentioned, but their payments are still going to be based on their discounts, which are still way, way more. I mean, the cost after the discount is still way, way more than what Medicare is going to pay. Okay, next slide. So basically what some employers have started to do is they've started to pay the facilities, for the most part, because that's where the big dollars are, a percentage of Medicare. So they're going to pay more than Medicare pays because they know the hospital is going to balk at that. But they're typically paying, say, 150% of Medicare. And so when you do that, you no longer need a network. You can tell your employees, you can go wherever you want. But we've got a plan and it's going to pay 150% of Medicare. And you might think, well, aren't the hospitals going to push back on that and balance bill the employees? Well, they might, but we're going to cover that on the next slides. So as I mentioned, they're going to pay your TPA that you're going to hire because the BUCAs are not going to do this kind of a plan for you because it blows up their business model. They're going to pay a percent of Medicare. And there's basically two types of strategies they use: pre-services negotiations and post-services. Pre-services are basically, everybody knows when you go into the hospital, it says on your ID card, you have to call your insurance company and tell them you're going into the hospital. That's called pre-certification. So in these models, when you call your TPA, which is what your ID card is going to have on it instead of the insurance company, they're going to call up the hospital and they're going to say, hey, Bruce is going in for a knee surgery. We are going to pay you X. It's 150% of Medicare for argument's sake. Are you okay with that? Most of the time, the hospital says, yes, we're okay with that. And so basically the payment has all been pre-approved on the front end. Your employee is going to be paying their share. And most health insurance plans, when you go into the hospital, the employee has a deductible and then it's 80-20. The insurance company pays 80 and the employee pays 20. Now the employee's 20% is based on 150% of Medicare, which is way lower than what they would have paid with one of the BUCAs. So when you do this pre-upfront negotiation, there's no surprises. There's no collections for the employee. So it's a great strategy. Next slide. The other one is post. And basically it is what it says. This is after the person gets in the hospital and the bill comes, they try to negotiate it. We're not fans of this approach. It does work well in some other states, and I'll show you why on one of the next slides. Doesn't work well in Arizona. Next slide. So basically, as I mentioned, the TPAs get minimal pushback when they use this approach. I know that's quite shocking, but they do. The healthcare facilities only push back between 2 to 8% of the time. So even if you get pushback and you as the employer decide you'll pay 170% of Medicare to get the hospital to agree to it, you're going to way more than make up for it on the other 92 than 98% of claims. And so you might say, why would the hospital agree to do this when they were getting 250% from the BUCAs? Well, to be contracted with Medicare, these entities have to sign like something that says that what Medicare pays allows them to cover their costs and provides for a reasonable profit. So if what Medicare is paying is allowing for a reasonable profit and your plan is paying 150% of that, it's pretty hard for them to say that's not a good deal. And one of the vendors that sells this, and they're not doing it in Arizona because of something I'll tell you about in a second, when they go to court and they say what I just said, the hospitals have learned that they don't really have a shot at winning this. Because if they've agreed that 100% of Medicare is a reasonable profit and you're paying them 150, the judge is not going to be very kind to them. So, when they go to court, they typically win, with the exception of Arizona and a few other states, which we'll talk about next. Next slide. So why would a hospital agree to it? Again, they don't want to incur the cost of litigation, and it's bad PR. If that kind of stuff gets in the paper, it makes them look like they're really taking advantage of people. Obviously, they don't want to do that. In Arizona, South Dakota, and North Dakota, however, case law has evolved to such that when your employee goes in the hospital, they typically have to fill out some admissions paperwork. I guess the hospitals in Arizona have in there that absent a agreement with an insurance company, the person has to pay what are called the charge master charges, which are the ridiculously high charges they charge people that don't have insurance. So basically in Arizona, if you do this after the fact, let's go to court thing, you typically are going to lose on that. So that doing this all on the front end model is what we would recommend. So if the employee gets a balance bill, what happens? They're instructed to notify the TPA, who basically takes over. They call the provider and say, hey, we already agreed to take the 150% of Medicare. You've sent this person a bill. We need to get you to not do that, etc. And again, if they don't come to an agreement on the front end and it has to be negotiated later, the employer is consulted and the TPA will say, hey, can we go up to 180% or whatever? And the employer gets to sign off on that. So it's not like they can just make you pay whatever they want. Next slide. What are doctors paid? Basically, the doctors, you can't save a bunch of money on doctors doing this. So basically, usually there is no network for doctors, which employees like. They'll still pay 20%, but the TPA will basically cover whatever they charge. It is looked at for reasonableness, but usually the doctors don't charge a ton more than what they do for Medicare. So you don't save a lot of money there. If you're concerned about that, you can rent a network just for the doctors. You can't really rent one of the BUCA's networks, but there are other networks out there that you can rent, and they don't have as good a discounts as the BUCA's, but you can rent them to save some money. How about drugs? You can't do this Medicare thing on drugs, so you need to hire a PBM, and again, your broker consultant would help you with that, and they will provide the drugs on this sort of a plan. Okay, next slide. So what are insurance companies doing about this? Well, to be honest, they're basically freaking out about it at this point. We have talked to some of them, and basically they are losing accounts to this, and they immediately come back with, well, your employees are going to get balance billed, they're going to be put in collections, the doctors are going to refuse to see them. We really haven't seen much of that at all, and a lot of that might be because this is relatively new. Who knows, maybe as it gets more popular, they will get more pushback. I will tell you, I have a client that's a big doctor practice. And when this came out, I contacted them about it and said, hey, are you aware of this? And, you need to be aware of it. And I said, when you get paid by what we call payers, which could be insurance companies or TPAs, do you ever look at what you're getting paid to make sure it's what your contract said you were going to get paid? And they said, frankly, we don't have the time or the systems to do that. As long as it meets a threshold, we just let them go through. So right now, I don't think healthcare providers are super sophisticated about this yet, but they might be. The other thing they're doing is launching accountable care organizations. Down here in Tucson, we do have one between Banner and Aetna, and that's kind of like a partnership between a healthcare provider and an insurance company, and you would be steered to the Banner people, and in exchange for that, Banner gives Aetna a really good discount. And if the providers do a good job of holding the cost of care down, they actually get some money back at the year end from Aetna. So those are getting more popular. That's the only one we have down here. There are several up in Phoenix, but those are becoming more popular as well. Next slide. So what are some of the considerations and potential downsides? What people pay hospitals based on Medicare varies tremendously by state. So So if all of your employees are in the state where the reimbursements say at 180%, you wouldn't be saving as much as you would be in Arizona. You need to consider whether switching to this is worth the disruption it might cause to employees. Usually there's not any on network because there's no network involved. But anytime you switch your drug provider, your PBM, if you will, there is disruption. Because if you switch from Blue Cross to United or United to Cigna or vice versa, or Blue Cross to a PBM, they're going to have different drugs that are covered and different ones which are not. They're going to be different copays. They're going to have different rules for taking some of the drugs. For example, prior authorization to take a drug, or step therapy where you have to try multiple drugs before you can take the drug that you wanted to get. If you've already gone through that with your old insurance company or PBM, you have to go through it again. So there is disruption on the drug. Again, I mentioned the balance billing thing, but if you do a great job educating people and say, don't freak out if you get a balance bill, just call the TPA, they'll handle it from there. You as the employer are only liable for what we told you you would be. Next slide. So you need to do a good job on employee education for this, obviously. It's a totally new concept. You've got to pick the right vendor. There are a lot of vendors offering this right now. I do know of one recently that will basically let you do a dual option between this approach and a regular PPO using the Cigna network. They will not let you do that if you have Cigna now, because Cigna doesn't want you to leave Cigna. But if you don't have Cigna now, you can do that. There's another one that will let you try it out for 6 months. And if you don't like it, they will switch you back to a PPO. But again, these are all under partially self-insured arrangements. So you would need to leave the easy button of fully insured to do that. Next slide. So before you go down this road, you really need to have somebody like us that's experienced and knowledgeable in this world. Partial self-insurance and self-funding is very complicated. There's a lot of holes you can step in. If you have a good consultant or broker, they already know what those are and you will avoid those. If you have somebody who doesn't know much about that and they're getting their feet wet, it's very dangerous. I'll give you one example. Lots of people have gotten in problems where they have their health plan set up and the stop loss insurance outfit that covers the big claims or more than expected claims on the group as a whole says, well, we know you had a gigantic claim on employee John, but if you look in the fine print of our contract, it says we don't cover experimental procedures and your health plan covered this and it's considered experimental. Or another one, yes, Mr. Employer, you went over your aggregate liability for your group as a whole for the year, but you're getting drug rebates back now from your PBM. And because you got reimbursed through those, we're not going to reimburse you for the amount that you went over. So those are just two examples. There's a lot of them. There's lots of ways you can get tripped up. So you need to have somebody good who's, aware of all this stuff. I will say a good intermediate step before you go down this road is this level funding product. Cigna offers it at, I think, 25 lives and up. I think Humana offers it from 2 to 50. I think Blue Cross offers it from 50 to 100. So that is a nice stepping stone product. It's basically, you still kind of have the easy button. You're all bundled with the insurance company. You're going to pay rates that look like normal rates. And at the end of the year, you can get some money back. If you have bad claims, you don't owe them anything. If you cancel, you can walk away. Your claims run out as covered. So that level funding is good, but you're still a covered entity under HIPAA. So you do have to worry about, having a privacy officer. And since you have the ability to look at claims, you got to make sure that the only people that can look at those are not going to talk about them with other employees. Next slide. So again, I've already kind of gone through all this. You need somebody who's familiar with all of this stuff. CBIZ is a big purveyor of these plans. We have a ton of them here in Tucson with large employers. So we know how all this works and who the players are, and we know how to avoid all those pitfalls. Next slide. The last one is about fees. When you have fully insured plans, the insurance company is paying the people like us a commission. If you're under 50 employees, it's not negotiable. It's whatever the insurance company says it is. And if you go direct, like you didn't use a broker, you're going to pay the same rates and nobody's going to get the commission. So you'd be kind of foolish to do that because you would want to get free advice. Above 50 employees, commissions are negotiable between the broker and the group. And then we tell the group, we tell the insurance company we've agreed on 5%, which is kind of the norm. And that's what it is. As you get larger, and if you go self-insured, there aren't commissions anymore, there are fees. And so you basically want to be paying the same fees, obviously, that you were when you're fully insured, ideally. We are willing to do that, even though it's a lot of additional work. The other reason you want to do fees is if you're fully insured and you get a rate increase, let's say you get a 10% rate increase, your broker is getting a commission increase because they're getting 5% of your rates. So when you go to flat fees, there is a better incentive for the broker, i.e., if they're giving you big rate increases, they're making more money. That's not the incentive you want. So when you go self-funded, you can pay fees, they're flat fees. They are built into the rates that you charge employees, so you're not paying them all. But anyway, that's just a little thing about commissions versus fees. Next slide. So anyway, this is just some more rah-rah about CBIZ, but we do have the ability to do all of the things that you need, as you can see on this slide. The actuarial, the wellness consulting, the pharmacy guy who does the pharmacy consulting. We've got great reporting. We've actually paid quite a bit of money for data mining software. So when we get your claims from the insurance company or the TPA, we don't just give you what they gave us. We have a program that goes through there and can mine it and look for things that you can fix. Again, an example would be you have a lot of diabetics. We need to get in there and do something about that sort of a thing. We also do all the compliance. There's quite a bit of compliance, even more so on self-funded than fully insured. Next slide. So if you want any more information about any of that, or you have any questions, you can reach out to me. My contact information is here on the slide. I'd just like to mention a couple last things. I frequently get asked, how many employers are going self-funded? Right now, for small groups, it's about 25%. And by small, I mean like 25 or more employees. That used to be like none. And it's getting bigger every year because more and more people are liking the flexibility to get out from the regulated Affordable Care Act market into the self-insured world where they have more flexibility and they can avoid taxes. So more and more people are heading that way. As an interesting aside, a lot of the states now, especially the blue states, they're kind of pushing back and saying, hey, we want to regulate self-insured plans. And they're not allowed to because self-insured plans are governed by the federal government. So in an attempt to circumvent that, they are trying to regulate the stop-loss insurance limits on self-insured plans and saying things like, hey, you cannot get insurance for claims at 40,000 and above where the insurance company takes over. You have to do 100. So they're trying to make it less attractive. Obviously, we don't have that in Arizona, but in states like California and some of the other blue states, they're actively trying to minimize the employers that go to self-funding because they view it as trying to blow up the Affordable Care Act. So anyway, that's my presentation. If anybody has any questions, please reach out to me. I'm happy to help you. I'm happy to give you some free advice. And with that, we'll take any questions and I'll hang on for a few minutes. But thank you for your time and attention.
Feel free to turn on your mic if you have a question for Bruce. Well, we thank everyone for attending today.
Thank you very much. If we can help you out, let us know. Thank you.
Have a good afternoon, everyone. Thank you, Bruce.
Bye-bye.